Hello, my name is Sheila and I'm a triage case management nurse here at our clinic. I wanted to discuss a noted increase in hospital readmissions as well as emergency room visits by our COPD patient population. In 2015, our facility was at 14% readmission rate for COPD patients and we were achieving our goal to be less than 20%. We are now seeing this number doubled for 2016. In 2012, there were 1,546 COPD patients in Greene County alone. There are 158,000 Wisconsin adult COPD cases per year, compared to 11 million COPD cases in the U.S. each year. COPD is the third leading cause of death in the U.S., killing more than 135,000 Americans each year, and COPD will increase by a whopping 30% in the next 10 years unless action is taken immediately. Interestingly, 1 in 5 patients will be readmitted within 30 days of discharge. And my research tells me that these readmissions are due to acute exacerbations that are a probable high-risk occurrence typical for COPD patients within 8 weeks after an initial exacerbation. COPD affects people for many reasons and is related to determinants of health as well as health disparities such as low income, education, occupation, race, gender, age, or family relationships. Bracken tells us that COPD unreasonably affects women, elderly, people without a high school diploma, the unemployed, and those with an annual income less than $25,000. Our community is in large made up of farmers, factory workers, welders, machinists, mechanics, and cooks, to name a few. These people are in an increased risk of COPD and COPD readmissions as they are exposed to poor air quality, increased likelihood of poor education, poor health literacy, inadequate health care coverage, and poor access to health care. Other reasons for high risk of readmission are being African American, comorbid conditions, and low socioeconomic status. A community assessment was completed using the community as a partner model. Gibson and Thatcher tell us that this is an ideal way of assessing a community by breaking it down into subsystems for easier organization as well as easier assessment. A thorough survey of the websites was completed, as you can see by the list I provided. I also extensively searched for evidence-based research articles related to COPD readmission rates, related causes for COPD readmissions, and solutions for these issues. Interestingly, I found out that the air quality in Wisconsin has been a key factor. The State of the Air report reported by the American Lung Association reports that people in Wisconsin continue to be exposed to dangerous levels of ozone, which is especially harmful to those with lung disease. Using this report, I researched the surrounding counties and found similar information. An ozone grade was given to each county between A and F, F being the worst. As you can see here from the information that I pulled, I feel this information is relevant for our increases in COPD readmission rates. It has been proven that patients with COPD, comorbidities, and increased poverty rates have higher readmission rates. These patients with comorbidities like cardiovascular disease, congestive heart failure, or depression must have increased services. Patients in our community have occupational exposures such as farmers from silo gases, welders inhaling fine metal particles, or factory workers exposed to chemicals. COPD affects all ages, races, and social classes, and access to appropriate health care, education, and management is imperative. Feimster tells us that COPD readmissions are associated more so to being of Black race and low-income communities. I've demonstrated that our community lacks resources due to unemployment or poor education, which causes a trickle effect and increases risk to health. In fact, Kaladuz, Nader, Yee, and Sharma inform us that people with a limited income have a higher prevalence of acute and chronic diseases and spend less money on screening services for chronic diseases. These patients are not being seen by their primary care providers, making unhealthy choices, and not utilizing existing programs and services. Patients on a limited income may live in unsafe neighborhoods, limiting access to fresh markets, outdoors, and transportation. A COPD surveillance report by Ford, Croft, and Menino, Wheaton, Zhang, and Wayne inform us that smoking is the most important etiologic driver of COPD, with 39% of the 15 million adults with self-reported COPD in the U.S. continuing to smoke. I obtained the total percentages from the County Health Rankings and Roadmaps website, which indicates that there continues to be a large portion of the population smoking in each county. Poor health literacy, which Lancaster tells us may be a stronger indicator of an individual's health status than age, income, employment status, education, or racial group, With each county's graduation rates, I feel that we have an accurate indicator of our community's health literacy. Here, I have listed the rates for you. Currently in our community, we offer Better Breathers Club meetings, which are held in our facility monthly. This is a support group developed by the American Lung Association featuring educational presentations, how COPD affects lungs. We also have the healthcare, hospice, palliative care, the Greene County Health Department, and the Aging and Disability Resource Center, which offers a variety of services like financial counseling, meal deliveries, home health services, housing options, prescription and drug assistance, support groups, and transportation options. My first community health nursing diagnosis is ineffective community self-health management. The community is exhibiting patterns of having difficulties integrating programs for treatment that can reduce their risk of COPD. Patients below poverty level, poor communication, lack of transportation, lack of access to programs offering immunizations, disease prevention, smoking cessation, or screenings. Based on my community assessment, this would be an appropriate diagnosis as these relating factors align with the COPD patient population in our community. Looking at the percentages of the population at or below the poverty level or the graduation percentages, this clearly indicates an appropriate diagnosis. My second community health nursing diagnosis is ineffective community coping. The community patterns of activities for change and problem solving are not meeting the needs of the community. Patients have a poor knowledge of resources, poor communication, and poor problem solving abilities, high unemployment rates, unsafe neighborhoods, and environmental issues. Based on my community assessment, I felt this was an appropriate nursing diagnosis as the relating factors align with the COPD patient population in our community. I was able to identify an environmental issue with the Wisconsin air quality that many people with COPD were not aware of. I was able to link this information to our increase in readmissions and to the fact that we do not have many resources available for our COPD population of patients to utilize. The Office for Disease Prevention and Health Promotion website has the Healthy People 2020 objectives listed. I've aligned my diagnosis to a few of these objectives. First, with environmental health, as this is promotion of health for all through a healthier environment. The number one objective on the Healthy People 2020 is to improve our outdoor air quality. Poor air quality can be linked to long-term damage to the respiratory system. Second is access to healthcare services, and this means improving access to quality healthcare. This means helping patients to access healthcare coverage and services they require. Limited access to healthcare can have a negative impact on a patient's overall health. The third objective is social determinants of health, and the goal is to create a social and physical environment promoting good health for all. This also means understanding how the community is impacted by the conditions of their environment and how it affects their health, functioning, and quality of life. My proposed intervention is implementation of case transitional care management. This intervention is based on my community's health diagnosis. These patients are unable to problem solve, making it difficult to meet their own needs by utilizing programs that are available. This intervention is designed to target patients on an individual basis with the intent to target the COPD patients with every encounter. We have a strong multidisciplinary team approach as the patient's primary care health teams will work closely with the hospital and emergency department teams. Primary care will promote prevention, education on self-care management, treatment of comorbid conditions, and regular healthcare follow-ups. Emergency and inpatient will promote pre-discharge education, self-care management, knowledge of worsening of condition, and how to contact healthcare when this happens. Krishnan et al. Tells us patients recovering from COPD exacerbations must have interventions that focus on self-care management skills, comorbid conditions, and coordination with ambulatory providers. Follow-up phone calls will be made to patients between 48 and 72 hours after discharge to check on patient progress. Patients will also be contacted on a regular basis based on severity of COPD. Tussaud et al. Discusses a risk measurement tool called LACE that stands for Length of Stay, Acuity of Admission, Comorbidities, and Emergency Room Visit in the last 6 months that grades the patient as either low, medium, or high risk. When necessary, there may be referrals to home care, hospice, palliative care, pulmonology, and respiratory therapy. We will also be incorporating the community programs that are available, such as the Better Breathers Clubs to all of our COPD patients, Greene County Health Department, or the Aging and Disability Resource Center to patients that we find appropriate. I am also proposing implementation of community education and counseling held at local churches or the YMCA monthly. This intervention is based on my community nursing diagnosis, as COPD patients have complex health conditions requiring community programs that have not been easily available for these patients. The multidisciplinary team members will work to offer monthly meetings at these locations. We will have a wide variety of topics to discuss, which I have displayed here for you. Lou et al. Proved in their study that community-based health education and physiological counseling improved COPD awareness and decreased anxiety and depression rates significantly. These proposed interventions I have discussed would be the secondary level of prevention. These patients have already been diagnosed. Our plan at this time is to prevent exacerbations and hospital readmissions with our case transitional care management, education, and counseling. This secondary level of prevention primary intent is to maintain the healthiest level of functionality as possible for these patients. Important considerations. The CMS are now penalizing hospitals with a high 30-day readmission rates. Feimster and Au tells us that this is an extension of the Medicare's hospital readmission reduction program, which hopes to improve quality of care, reduce costs, and create financial incentives for hospitals to prevent readmissions. We will utilize current hospital and clinic staff, as well as cut down expenses by utilizing our student population for our monthly community sessions. There will be cost considerations such as case management certifications for our nursing staff, as well as office supplies for our community education and printing costs. Funding that I have investigated is a Service Area Competition or SAC grant through the Department of Health and Human Services. Grants.com states that eligibility requirements to be a public or nonprofit private entity or a faith-based and community-based organization, tribe, or tribal organization. Another grant is through the American Lung Association called the Clinical Patient Care Research Grant, which has the potential of awarding the facility up to $40,000 per year. Community readiness will be assessed by collecting data from all stakeholders in the community, as well as population needs assessment. Stanhope tells us that this is a focused assessment on characteristics of a specific population, their health risks, health needs, and resources to achieve their needs, and it is vital to avoid planning services that are not focused on this population or provided by other agencies. And this is my COPD logic model. Evaluation involves monitoring the program to provide evidence that the program is meeting the needs of the COPD patient population and readmission rates. Information can be gathered by conducting surveys, interviews, and observations to assess all stakeholders. We will continue to monitor community statistics as well as COPD readmission rates and reasons for readmissions, along with incorporation of these new interventions to evaluate the impacts of the interventions. Cost-effectiveness analysis can be performed in this situation. This measurement does not put a dollar amount on the outcome, such as quality of life. As Stanhope tells us, public health measures are not always the most cost-effective, and the cost-effectiveness may not be known until several years in the future when we see the actual results of our preventative services. With any new intervention, the first attempt at change will not be the most effective means for change. This means we will implement plan, do, study, act cycles of change until we reach the ideal state for our COPD patients and healthcare organizations. COPD and COPD readmission rates are prevalent in our communities because of social determinants of health. Addressing the Healthy People 2020 objectives targets the social determinants. A recent assessment quiz by the Association of Academic Health Centers proved that we scored high in addressing social determinants of health. By approving this plan and incorporating these proposed interventions, we will be able to meet the needs of the COPD patient population. With 1 in 5 patients being readmitted with COPD exacerbations and COPD deaths projected to rise 30% in the next 10 years, this is not just about decreasing COPD readmission rates. This is about changing the view of COPD and educating these patients on self-management and their exacerbations, which will result in a decrease in readmission rates and improving quality of life. The causes of COPD exacerbations and subsequent readmissions have been clearly laid out for you today. In our community, we are having issues with poor air quality, job exposures, poverty, poor education, poor health literacy, and poor access to health care. Smoking cessation programs must also be expanded in our communities to impact COPD in the coming years. The proposed interventions of case transitional care management, community education, and counseling are individualized, personal, with a broad community twist. Our focus is on self-care management for these COPD patients. We want to make sure that we are boosting our efforts to meet the requirements of the CMS by decreasing our COPD 30-day hospital readmission rates. Even more so, we want to ensure that our COPD patients have an improved quality of life as well as improved overall health. Thank you very much for your time today, and if you have any questions, please feel free to ask.